Hey folks, this is Jessica Mashkovich, host of One Take with Jess. Today, my guest is actually a longtime friend and Dr. Ken Tomkovich. Hey, Ken.
Hi, Jess.
So I had ChatGPT, my new best friend, write out the intro, and I asked it. I said, "Please summarize a short intro for guest Dr. Kenneth Tomkovich from New Jersey, based upon his past experience, his specialties, expertise, and innovation." That's all I asked it to do. And it loves you. It basically said, "Ladies and gentlemen," in that voice. It doesn't have a voice, but if it did, it would be, "Ladies and gentlemen, please join me in extending a warm welcome to our esteemed guest, Dr. Kenneth Tomkovich of New Jersey. Dr. Tomkovich is a renowned expert in the field of medical imaging," correct, "with a focus on interventional radiology and minimally invasive procedures. With years of experience and extensive knowledge of this domain, he has made significant contributions to the advancement of medical techniques in patient care. Dr. Tomkovich is recognized for his innovation in developing novel diagnostic and therapeutic approaches, which have greatly improved the lives of countless patients." All true. Let's lend our ears to this distinguished specialist and learn from his vast expertise in the ever-evolving field of medical imaging. Isn't that great?
That's really nice. I'm glad ChatGPT likes me.
That's right. This is your legacy. The
Wow,
machines will know that you did good things.
that's great, Jess.
Maybe
Very,
they
very
will spare you.
right.
Oh my gosh. Yes, Ken, you and I go way back, and there are so many times where I'm engaged in conversation with you and I just can't leave because the conversation is just so intriguing. You are an interventional radiologist, and you have done great work that you've explained to me regarding breast cancer, especially this procedure called cryoablation, a new way of dealing with breast cancer tumors. And I wanted you on here just to talk about it because 1 in 8 women are going to develop breast cancer at some point. You can correct that statistic if I'm off because you're the
Yeah,
expert.
that's pretty accurate. Yeah, that's correct. Yeah.
So
So
you,
go
I'm
ahead.
sorry, go on.
Well, I was going to say, I mean, it's really nice to be able to speak to you about this, and I know we talked about this for a while. I think your podcasts are great. I've listened to a few of them, and very interesting. And I'm happy to be here to share a little bit with you and with the audience. I'm very passionate about this topic. I think I've expressed that to you before. As you said, there's 1 in 8 women that in their lifetime are going to get breast cancer, and the fact is that there's really very little that we know in medicine today to prevent that from happening. So there's a lot of diseases where we have medications we can prescribe, or we can tell people about lifestyle changes. And when it comes down to breast cancer, there's very little about breast cancer that we can say, okay, do this and you won't get breast cancer. So that being said, how do we affect women's lives? How do we affect this whole disease process going forward? And it's certainly something that to me was intriguing when I started my career as an interventional radiologist, which was, I just came from medical school alumni night last week, where we had a career night where they invite alumni to come back. So when I was there and speaking to the students who were deciding on their career paths and explaining to them what I do on a daily basis and what I've done in my past career, I had to do a moment because I've been 30 years since I graduated medical school this year. So now I feel old. But so that being said, I am though, and I have a lot of knowledge of this topic. And so how this started with the breast cancer cryoablation was I trained as an interventional radiologist, which is someone who does minimally invasive procedures using imaging guidance. So we use X-ray machines and we use CAT scan machines and ultrasound machines to guide us to do kind of minimally invasive surgeries, usually with local anesthesia, sometimes with IV sedation, like you get if you were having an endoscopy procedure or something like that. But most of them are done on an outpatient basis, and patients recover very quickly. And I love this field, and I've been really involved in this field since I finished my training, which was in '99, out in Colorado. But then when I came to my current job in New Jersey, there wasn't a lot of there weren't a lot of physicians who were really passionate about the breast stuff. So I said, I'll just do the breast stuff because, it wasn't part of my training, but these breast procedures, breast biopsies, breast interventions were important to me. So that's how I started this whole breast thing. And from that, I started doing breast biopsy procedures and using the skills that I learned in interventional radiology, which really wasn't part of the breast biopsy field per se. It was like two separate fields from an academic standpoint and a training standpoint. But I used what I learned from the IR world in the breast world. And when I comboed the two, it was just a perfect fit for me. And I realized that I could develop new biopsy procedures and techniques and train other physicians, not only here in the US, but around the world, and how to do these procedures better.
So how was this an advancement for the patient? For example, were they not having to be opened up or, go under general anesthesia? What were the advantages that you brought to women, to patients that were undergoing certain procedures?
When I started doing these breast biopsy procedures, many physicians were doing them. I wasn't the first one to do them. I was kind of picking up on what had been done already, but I was comboing some of the techniques that I had learned in the interventional radiology field. So for things like biopsying a liver or biopsying a lung or biopsying a thyroid or something, another organ, and apply that to the breast from an interventional radiology standpoint. And in doing so, I think it improved some of the techniques. I had some really good results, meaning we were 100% concordant. And what that means, Jess, is that when we do a biopsy, the result is the same as if they would do an open surgical biopsy. So these were percutaneous image-guided biopsies with tiny little incisions, no cutting, no sewing, anything like that. And doing that, I ended up presenting that data at national meetings, and then ended up writing a textbook chapter on it. And then it kind of things took off from there as far as being recognized and giving presentations. And I ended up being invited to go to China, and that's kind of a different story. But
actually, that's a good story. I like that story because you were in China presenting on the cryo side of things, the cryoablation, weren't you?
Yeah, well, and I first started out in China, just kind of teaching them how to do the basics of breast biopsy, because they were still, at the time that I'd been there, which was 2010, that was my first visit to China. They were doing a lot of open surgical biopsy still, because physicians really hadn't, from the West, I guess, got there and helped them and trained them and said, listen, these are, and they had all the skill sets to do it. They just weren't taught on what they should be doing. So I went from place to place to place in China, and they were extremely receptive and very nice and very welcoming to the thought that maybe they could do things differently and improve the quality of life for their patients. So I started out by teaching them just the basic biopsy stuff because some of the centers, they weren't even doing these image-guided biopsies. They were just still doing open surgical biopsies or even mastectomies in patients who might have had benign disease. So
wow.
That was really a big change for them. And when I was able to teach them what they could do, they quickly adopted it and invited me back for several meetings. Even had a group of docs from China come here to train in the US back in 2012. And that was a great experience. So I've been there 5 times. And over the years, how we got into the ablation part, which I'll, with that as a little background, the ablation stuff started because in interventional radiology, we have been ablating. And by ablation, what I mean is that you have a tumor somewhere in the body. Typically, this was started in the liver. It also has been done in the lung. It's been done in the kidneys. It's been done in bones. And it's been done for years. For 20 years plus, we've been doing ablation procedures in these different organs. And what that means is that, let's say you have a tumor in your liver. We would find the tumor by imaging, either by ultrasound or CAT scan or MRI. We localize the tumor, and then we do a biopsy. We do an image-guided biopsy where using either CAT scan or ultrasound or some other modality, we would then place a needle into that tumor, take small samples, send it to the pathologist. They analyze it, and then they come up with an answer what it is. So once we've proven that that is a tumor, then we typically would go to a tumor board at most institutions where we say, okay, Mrs. Smith has a liver tumor. How are we going to treat it? Can we resect it? Does she get chemo? Does she get some other kind of therapy? And one of the things that was offered back in probably the late 1990s was this ablation therapy, where we would place a probe into that tumor and flip a switch. And usually it would either use extreme heat or microwave technology or extreme cold technology, cryotherapy, to freeze or heat kill that tumor. And that's ablation procedures. So that being able to put a probe into a tumor specifically, precisely by image guidance was really a great advancement, and really something that opened up a lot of therapeutic options for patients who just didn't have them in the past. So things have kind of advanced since there. But the point of this is that we were doing it for liver, we were doing it for lung, we were doing it for kidney. And I'm looking at all the data and saying, I'm really involved in the breast stuff. Why are we not doing this for breast? It seemed pretty logical that if we're doing all these other image guided procedures for the breast, why are we not doing thermal ablation for the breast? And there's a lot of backstory on why that wasn't being done. But it took me about 4 years of researching this topic and trying to figure out why it wasn't being done, to try to figure out what had to be done to make it work and make it acceptable. Because really the standard of care is surgery. So most women who are diagnosed with breast cancer have some type of surgery, unless it's just very bad malignant disease and it's already stage 4 and unfortunately metastatic, then maybe they aren't surgical candidates. But most women diagnosed in the US and around the world with breast cancer are surgical candidates. So in order to make this work from a procedural standpoint, you had to kind of come up with a procedure that was going to be close to, if not better than, the open surgical procedure for people to want it. Otherwise, they're going to say, well, why would I want this? I'll just have surgery. So that was kind of the background and how we started with the cryoablation thing. But it was going through all this data and all these papers and all this minutia. It really was a good 4-year process, Jess, and trying to figure it out. And it was like, what I described it was like, it's like trying to solve a Rubik's Cube. It was all messed up, and we had to spin it and spin it and spin it. And I kept spinning it until finally it kind of clicked. I was like, that's the combination that I think is going to work.
So was it a combination of factors of the tumor being the right size? And so was it more environmental factors, or was it more procedural factors? Did you need the right tools, the right people, the right machines?
Yeah, that's a really good question, and very insightful, because it was a combination of all those things. So what happened was I came across this technology for cryoablation, which is using extreme cold to thermally cool a probe while it's in the breast or in any organ. So this is being used for other organs, but we then applied that technology for the breast. So the probe was really good in that it created a spherical ice ball large enough to engulf a certain size tumor and to have enough of a kill zone and a margin around it. Because what we wanted to do was we want to not only make sure that the tumor itself is dead, but we want to get a safety margin. So a surgical margin these days is around only 1 millimeter or 2 that the surgeon say, okay, that's good. We got the tumor out. We got 1 millimeter or 2 of normal tissue. What I wanted to do with my study was to come up with a way that we can get a safe 10 millimeter margin of kill zone around that tumor, so that I knew that we were going to, be successful. And even if we were a little off in the placement of the probe, we still had a margin of safety for the kill zone for the tumor. So the technology had to be good. It had to be something that could be done percutaneously, image guided. We went back and forth with, should we use heat ablation or cold ablation? And it's pretty clear that our decision to choose the cold was the best one, because when you do the cold ablation, you put ice on something that hurts. Well, the cold works as its own anesthetic in the breast. So all we need to give is a little bit of numbing medicine, a little local anesthesia, similar to what you get in the dentist's office, or if you're getting stitches. We just numb up the area, put in this probe, flip on the machine. We do a freeze, thaw, freeze cycle. So we allow, in the middle of a passive thaw of the tissue, to allow water to get back into the cells, so that some of the cells that are not completely dead, then that second freeze, which is also a key, really kills the tumor and kills the a little bit of the normal surrounding tissue, which is okay, because it's not a large area that we're treating anyway. The other thing was one of the keys was that a lot of these earlier studies were being done where they were treating all comers, meaning all different tumor types and cell types and subtypes and different sizes, and that didn't work. So what we focused on was treating a tumor size of 1.5 centimeters and less. And since then, I've treated larger tumors, but a part of my ICE3 national trial that I was one of the co-principal investigators on. That trial, we focused on 1.5 centimeters or less and low-grade tumors, meaning now we can test when we do pathology slides, we can test for different subtypes of receptors on the surface of the tumors, estrogen receptors, progesterone receptors, other types of receptors, not to bore everybody, but basically there's certain tumors that are good behavior tumors and certain ones that are bad players. So you may have heard of triple negative breast cancer. That's ER, PR negative, HER2 negative. That's one of the bad players for breast cancer. So we excluded those from our trial. We didn't want to treat those because we weren't sure we were going to be successful. And we wanted to make sure that those women had the optimal care because those people needed like chemo and other type of things in combination with surgery. So we picked kind of these little tumors that were behaving themselves from a hormone receptor standpoint. But in fact, Jess, that really is what I see in about 60% of my practice on a daily basis. So the tumors that we treated for this trial, it encompasses about 60% of all the tumors that are diagnosed in the United States.
Yeah, they're the most common. It's
Yep.
almost like it is the low hanging fruit. You know, it's the ones that are most going to respond to this treatment. And it's also the most common that walk through the door. So you're really kind of broad stroking a big population. How does this improve? I come in with a breast tumor that looks like it might be a candidate for what you're talking about. What is the difference? What differences happen when I go in for the procedure versus if I were to do it the traditional way and have it removed by a lumpectomy surgery?
Right.
What's my day look like?
Your day, it's, you know, part of the thing with this procedure is not only is it working great, but the benefits of the patient from multiple factors. You know, if this procedure wasn't as successful as it is, I'd say still it's a good procedure because of all these other benefits. Meaning, you don't need anesthesia. It's done as an outpatient setting. It takes about an hour to an hour and a half to complete. You're awake and alert the whole time, so you don't have to go, you know, through that whole preoperative workup and IV and seeing an anesthesiologist and all that you have with surgery. There's no cutting. I mean, all we do is make a tiny little pea-sized incision in the breast, big enough to put in this probe. So you don't have all the stitches and sutures and cutting and scarring and all that stuff that's associated with surgery. You go out, you know, the same day and you're back to your normal routine. I mean, people usually go out to lunch after they have this procedure when they do with me. So all of those reasons make this procedure so much better than the normal surgical procedure that's offered to most women today, anywhere you go for your breast cancer therapy around the world.
So can I ask for this procedure? Is this something that I would, you know, ask my breast doctor? Like I really would opt not to have the lumpectomy. Can you cryoablation it? Is this something that's become a little bit more
soon? Maybe. I mean, so the trial, there hasn't been a lot of trials published. And the trial that I'm the co-principal investigator on, it's just called the ICE3 trial, ICE3 trial. Is still, we're finishing up with following all of the data. And then we look to publish this data and come out with all the final data sometime in 2024. So hopefully by this time next year, it'll be out there in the news and it'll be kind of, you know, more widespread knowledge of it. But, you know, people like yourself sharing these podcasts and all, it's good that the general public gets to hear about this because, you know, it's been so successful to this point. I've treated a number of patients through the trial in my institution, and the trial encompassed 19 centers from around the United States. So it wasn't just one place. We treated close to 200 patients, and to date we have a 97% success rate. The best surgical success rate is around 95, 96%.
Okay, so
So,
you're in line with them, and patients have
right,
gone to lunch after the procedure. So it is a lot more minimally invasive, a lot more emotionally non-event. I'll even say, because I know what the emotion is in going through a surgery, especially a breast surgery,
oh God,
and having this type of procedure just eliminates probably 90% of that whole emotional baggage and worry that you may have.
right, right. But right now it's not readily available. I am encouraged though, because when I started this process, like, I don't know, I want to say like 12 years ago, I was at a conference, giving a conference about this potential topic. And my colleagues were saying, you're crazy, don't do this. This is not going to work. You know, you're dealing with breast cancer. It's its own little, it's its own specialty, and surgery is the gold standard, and don't even try to ablate this. Well, now, a few weeks ago, the American Society of Breast Surgeons, who are my colleagues and a lot of my friends, were up in Boston. They had a whole symposium on cryoablation for breast cancer as part of their annual meeting. We, at the Society of Interventional Radiology meeting this year, had a mini symposium on cryoablation for breast cancer as part of that meeting. So it's out there. I was in Europe last year in Vienna, Austria, at the European Congress of Interventional Oncology, which is super specialized for interventional radiologists who deal with oncology. We had a session at their meeting. So it's getting out there. It's getting more legs. More people are hearing about it. More people are interested in it. And I think it's only a matter of time before it's going to become a new standard of care. And I think it's going to be a really, really great option for a lot of women. And I'm super happy and excited to be part of this.
That's awesome. It is just out of my own curiosity, is cryoablation, does it work better for cancer cells, cancer tumors, or can it be used on any tumor just as a better means of surgery?
Yeah, I mean, cryo procedures have been used to treat benign disease for years, like skin conditions, and dermatologists have used cryotherapy for years. It's also been used to treat benign tumors in the uterus, benign tumors of the breast. So it has benign applications as well as the malignant applications. One of the really kind of neat sub things that's going on with the cryo, and I'm working with some colleagues of mine in MD Anderson in Texas, the big cancer center. They're looking at now, if you freeze something, this is my best analogy. Why? So not only is cryo good because the anesthetic effect, but cryo, when it kills the cells, it denatures them, and what happens is the body resorbs the tissue. So like if you bruised your thigh, you have a big bruise, but a few weeks later the bruise is gone. Why? Because your body sends in macrophages and other cells to chew up the dead tissue and get rid of it. What happens when we do the cryoablation procedure for the breast is we freeze and kill the tumor, and it unmasks those tumor cells. So then the body goes in and starts to chew up this dead tissue, but it says, wait a minute, there's something wrong. This isn't normal. So the reason cancers grow, and you probably have heard about immunotherapy being used for treating different types of cancers now. The reasons cancers grow is because they have immune checkpoint inhibitors, right? So they block the normal immune pathways from finding it. So it grows unencumbered in the body because the body thinks it's just something normal that should be growing, right? But that's the way cancer works. We're finding out now that through cryotherapy, perhaps we are going to be able to unmask those cancer cells. And there's some of the research that's going on at MD Anderson, and there's going to be some new research coming out of Sloan Kettering, is using cryotherapy in combination with these new immunotherapy regimens to perhaps treat metastatic cancer in a new way that we couldn't do before because the tumor was masking itself from the immune system. So that's a really great sub-benefit of this whole cryotherapy thing, and the fact that this trial was the first trial where we froze the tumors, and I got to give a shout out to all of the patients who participated in this trial. They are the real pioneers and the real champions of this procedure. The women who I've treated are just amazing people. Some of them went against what their families' wishes were. Like their family said, don't let this doctor do this cryotherapy thing because we want you to have the regular surgery because we want you around. And I remember one conversation from one of my patients, her daughter was there, very upset with her. And I was going through the whole consent. And she said, listen, I want to do this because maybe this is going to make a better life for you and a better life for my grandkids by doing this procedure. Maybe it won't work, but if it does, it's going to be a better thing. So congratulations to her and to all these other patients for really trusting in me and trusting in the other investigators to try this and see if it was going to work. And it's just been an amazing journey, you know, doing all this work with the cryoablation for breast cancer.
Absolutely. Is there going to ever be a time where we can hop into like a cryo chamber, freeze our entire bodies, and then unfreeze our entire bodies, and then any cancer that's looming in there will have been unmasked, and our bodies can do what they want to do, what they need to do, and go fight it wherever it's at?
Who knows? That's like Han Solo Star Wars stuff, right? I mean, it's listen, some of the things that we're doing now, as far as imaging and you know, the types of diagnosis that we can make and the different, even you know, just talking about this cryoablation for cancer, for breast cancer specifically, 10 years ago, this is a pipe dream. There's no way we're going to do this, and we're close to it now. So I'm not going to say no, that's impossible. I don't know. Maybe the technology 50 years from now will be such that you could do something like that.
Yeah.
I don't know there now, but I'm going to focus on my little big that I'm doing right now and work on that for the near future.
Okay. For now, I'll work on the big plan, the master plan. That doesn't sound right. Okay, so let's shift gears. That's great, and I want you to continue doing that because I've continued to be amazed at what is going on. You know, like first it was heat, let's burn it off, and then now it's like let's freeze it off. And I love where the technology is going, and I hope it becomes broader and broader.
Actually, before we switch topics here on the cryo stuff, is that here's what I kind of envision, what I can kind of see for the future, is that I really want to see this have a secondary effect on all the women listening to this podcast and around the United States and around the world to kind of change the way everyone thinks about breast cancer. Meaning right now there's a huge fear factor, and I get it. And I deal with these patients every day, and I try to be, you know, as sympathetic as possible and put myself in your shoes, which is impossible. But you know, I understand this diagnosis of breast cancer is a huge thing. It's a life changer. And there's this whole other psychological thing about, am I going to lose my breast? Am I going to lose my dignity? Am I going to be disfigured? I'm going to have chemo, radiation, all this kind of stuff. And it's a huge deal for women, right? So here's what I want to propose. What if I told you that there's a procedure that I can do in my office in an hour where we put a probe in, freeze your cancer. Maybe you need some radiation, maybe you don't, maybe you need a little bit of oral therapy, maybe you don't. But basically in an hour and a half, your cancer is dead and you're done. And that's the way we treat your breast cancer. And 5 years later, which because I followed patients for 5, 6, 7 years now, your breast looks exactly like it did when you walked in. You would never know looking at this woman's breast that anything was done to it. So how does that now change the thinking about breast cancer such that just what I want is if people think about this procedure, we start implementing this on a more wide scale basis, women are going to come in sooner for their diagnosis because if the cancer gets too big, I can't do this, right? So what I want to get out there, that message is that by doing this procedure, and you got to come in for your mammograms, you have to come in for your ultrasound. You can't be scared about getting a diagnosis because the sooner I find it, the more likely I am to be able to treat it with this. So hopefully the benefit in the outcome will be a decrease in the fear factor for this whole thing, an increase in the number of women coming for the mammograms, coming for the ultrasounds, and an overall decrease in the morbidity and the mortality from breast cancer because we're finding the cancers earlier when we can treat them with cryoablation. And we're going to affect the lives of millions of women in the future because of the fact that we can do this procedure and offer this to them, and there won't be that fear factor and stigma that there is today. So that's my overall goal.
That's amazing. And I hope that those words, you know, ring in many people's ears that they really do need to do that. Are most of these early stage cancers detected in the yearly mammograms or by self-diagnosis? How are you developing? How are people noticing that they might have a lump or early stage?
Most of the cancers that we're talking about in this trial, if you get out a ruler 1.5 centimeters or less, we're talking grape size or smaller. And we find those on a daily basis by mammogram and ultrasound. That's usually the two ways. Sometimes supplemental MRIs are done. We can find them, but not infrequently. It's the yearly mammogram. And if people have more dense breast tissue, a supplemental ultrasound, or we'll see something on mammogram and we'll say, okay, you have something on mammogram. We want to look by ultrasound and see what that looks like to characterize it better. And then we use the ultrasound to guide us for the ablation procedures. But these are found almost all the time. Women don't physically feel them. Women aren't doing a breast self-exam and go, oh, I have a 1.5 centimeter cancer. These are found by the yearly mammograms and the ultrasound screening studies and the other things that we do as part of our well visits and our screening studies that we offer to the women of our community.
Okay, so that being said, girls, go get your boobs checked. Go get your mammograms every single year. You never know what you're going to find, and if you find something, it's okay. It can be handled. It's okay. I actually always send Ken my results. Dr. Tomkovich. He's probably the only man around, my little circle of friends here that sees my boobs on a regular basis through mammogram, because I always want that look-see to make sure. So thank you for that, Ken.
Yeah. Yeah, no, that's, I mean, there's so many people that I'm friendly with that I have that professional relationship with, because and I thank you for trusting in me to do that, and there's a lot of women in this community and in my workplace that seek me out, as well as my colleagues, to do that and make those diagnoses, and we're happy to do so.
Perfect. Okay, so another topic. Can I switch topics? Because I'm glad that you pointed that whole other section out. That's so important, super important. You are also doing work with an AI company that helps, I guess, highlight or call out what might be malignant, and also helps, doctors and radiologists prioritize what to look at. There's always been your method, which I'm sure you'll talk about how it is now versus how it looks in the future, and where the benefits of AI in medicine can be found. But talk a little bit about your contribution to helping advance artificial intelligence in this field.
Yeah, so AI in medicine has been something that's been developed or in development for years, and it's really coming to fruition more recently. I think it's something that really we as physicians need to embrace, and not really worry about them taking over, the computers taking over, and we need to be smart about how we use this technology. So what you're alluding to is that for years we've used in cancer detection for mammography something called computer-aided detection services. So when someone has a mammogram, the computer analyzes that mammogram and says, okay, look at here. These could be all abnormal spots, right? So it's been very sensitive, meaning it'll find a lot of things, but not really specific. So it still needs the professional eye of someone like myself to look at it and determine, okay, don't worry about that. That's just a benign calcification. Oh, let's look at that. That could be a malignant calcification. Okay. So the computer has not been able to, at this point, figure out what's what. Now, fast forward to 2023, the computers are getting better at that. So there are certain computer algorithms out there that are using AI to process what we're seeing, not only on a regular mammogram, but on 3D mammography, which cuts little slices through the mammograms, and ultrasound. And I think it's just going to improve the diagnostic capabilities of the physicians, because, and also maybe we're going to be able to differentiate and at some point say, okay, that's really got a really good chance of being malignant. We want to combo that with the biopsy and some therapy. Or, you know what, that thing we know from AI, it probably has maybe like a 10% chance of being malignant. So we could have a conversation with the patient and say, do you want to have a biopsy right now? We could find out 100% sure with a biopsy, or you want to wait and because it's a 90% chance it's something benign. So then that helps individualized care as well. AI is also being used a lot now with the emergency department. So a lot of what we do as radiologists, I don't know, the general public knows, is that you go to an ER, and not infrequently now, you'll say, I have abdominal pain, and they order almost immediately a CAT scan of the abdomen and pelvis, or an ultrasound of the right upper quadrant to look for gallstones or something. So the AI is helping us now with the CAT scans in prioritizing which scans we need to look at. Meaning there may be 5 or 6 scans in a queue that come up on a daily basis, to be read at the same time or almost simultaneously. But the AI will scan through them and say, hey, wait a minute, that one, I think there's a collapsed lung. You better take a look at it. So it jumps it up to the top of the list. So then I click on that and I say, oh yeah, the AI was right. That is a collapsed lung. Let me call the ER. Let me get this person a chest tube so they can reinflate their lung and be treated quicker than had it just been sitting at the bottom of the list. So it does that with brain hemorrhages. It does that with other conditions, like if you have air in your abdomen that shouldn't be there, it's outside of your organs, meaning there's a perforation in your abdomen. It looks for that. So AI is getting better at helping us prioritize what we do. But still, we need the human eye at this point to look at things and figure out what's normal and what's not normal.
Yeah. And it works. It gets its knowledge based upon the information that you feed it. So you have to continuously educate it and be like, this is a malignant, this is a calcification, this is a benign. So are there doctors working with these information repositories or wherever it's pulling information just to make sure that it is highlighting the proper thing and that it's not being fed misinformation in terms of just the diagnostics of these images?
Yeah, absolutely. One of the projects that I was involved in was early on with COVID. I was able to participate in the American College of Radiology. It's the biggest radiology organization in the US. I think one of the biggest in the world. It might be the biggest in the world, I'm not sure. But the ACR, we got together a group of physicians who decided to make a COVID task force, an imaging task force. And I was part of that on the ground floor. And part of that was to put our knowledge together and come up with an image database of all these images of COVID and what COVID looked like, and chest X-rays, in CAT scans of the chest, in other imaging modalities, fed it into this large system that was based in Chicago. And through that, what we did was we were offering feedback to the system to say, okay, this was COVID, but we also had to give it normals. So it knew what was normal as well. So we gave it a bunch of normals, we gave it a bunch of positives, and then it helps. And this database is now built so that if we get faced with this in the future, again, or something similar to it, we'll be able to recognize it. It also helps us with determining what different characteristics of long COVID may look like on chest CTs or other imaging modalities. So yeah, to answer your question, we have to tell it what's right and what's wrong. And part of these AI algorithms that we're using now through the ER, so let's say it says that there's a collapsed lung, and it makes me go look at that first on the list. And I look at it and I go, no, you're wrong. That's just some kind of an artifact. That's not really a collapsed lung. There's a button you can push and give it feedback. So you tell it, nope, sorry, that's wrong. And it somewhere in the back end, beyond what I know for the computer to do, it processes it and it analyzes it and says, okay, Tomkovich said that's not a collapsed lung. Let's figure out why, and let's just kind of use it and learn from it. So the computer, we still, even though we're using it, we're helping it to learn and improve itself through our experience.
So is there ever fear of it taking your job, or what sort of jobs might it take? It sounds like it's doing a little bit of the triage side of things in helping that area. But so if you were a medical student right now, what might you send someone in the direction to be like, in 10 years, what you're studying now might actually be done by the machines. So get the biggest bang for your buck and switch to something else.
Right. So in my field of medical imaging and radiology, there's this fear that the computer's just going to read all the x-rays for us and that we're not going to be needed anymore because the computer's going to read the x-ray and it's going to use ChatGPT to generate a report and you're not going to need a radiologist anymore. It's just going to computer analyze it. I just know my experience from the mammography side, where for the past more than 10 years, we've been using computer-aided detection. And as I said, Jess, it's really sensitive. It finds a lot, but it's not anywhere near specific. Is it going to get better? I hope so, because sometimes it makes my job more difficult because it's lighting up 10 different things that are all normal. And I'm like, that's all normal. Just please, I don't have to really.
But you have to teach it. You're teaching.
I'm teaching it, right? So as far as the medical field goes, like I said, I think that we have to embrace AI. We have to use it in a good, meaningful, helpful way. Like, so triage would be great, but brain hemorrhage, let's say, okay, it finds brain hemorrhages in CAT scans of the head. So again, that's something like if someone comes in for a stroke, they have a brain CT. If AI sees a hemorrhage, it puts it at the top of my list. Now, what AI doesn't do is it doesn't know that that hemorrhage was there for the last 2 weeks, and I've seen 10 CAT scans on the same patient with the same hemorrhage. So it puts it at the top of my list. I'm like, oh, that's Mr. Smith. I know he has a hemorrhage. Yeah, fine. Okay, let me just click off that and get rid of that and go on to the next case.
Well,
so
the hemorrhage is probably not an emergent situation at the moment, right? I mean, Mr. Smith still might need your attention just because he's had it.
Right. I'm saying it can't, it's not good enough to think at this point, differentiate it's acute or it's chronic or it's new or it's bad or it's gonna, still as physicians, we have to put together, one of the things I love about radiology is that it's all encompassing. So meaning like when you're a radiologist, you have to kind of know what the pediatrician is thinking. You have to know what the cardiologist is thinking. You have to know what the orthopod's thinking. And you have to use all those skills and put everything together and work with all those other groups of doctors, right? So I think that'd be tough for AI to try to figure out all those little things in minutia. Will it get there? It's possible. Certainly, I think, robots help with surgery now, but are you going to have someone who's able to be skilled at placing a probe into the breast and killing a tumor as a computer? I don't know how that's going to do that. I'm not really sure.
Maybe flash forward, 5 years, 10 years from now, it might be more like the what's the name of that robot that does surgery? It's got a name. Da Vinci. Da Vinci robot. Da Vinci. Yeah, that's been around for a little while, and I assume that's been getting better and better.
It works at the control of a physician who's manipulating the robot like you would a video game. So it doesn't, you don't just tell it, go take out a gallbladder. It needs the doctor to use it to take out the gallbladder. You follow what I'm saying? So it's the robotics are great, but they're not working independently by themselves. And I can't see them getting there anytime soon. But, again.
That might be a skill that we recommend to young people right now is just up your video game playing.
It could be, yes.
Yeah, dexterity and hand controls are probably a thing in the future, just in case.
Absolutely. Yeah.
Yeah. So, so radiology is not in jeopardy at the moment. However, you'll be retired by the time it comes around. You'll be consulting for AI companies and just helping them, build those things that are going to take other people's jobs.
What I do, I can't see retiring anytime soon, but just not hitting my prime, right? No, it's. I mean, I think the physicians of the future are going to have a lot more stuff to work with and to utilize to affect patient care, and hopefully AI will be part of that, and it'll be implemented into medicine. And there's a lot of there's a huge need for doctors, and there's a huge need for people who are, empathetic and thoughtful, and sometimes AI is actually. I read some articles that people like to chat GPT bedside manner than their own physician's bedside manner. So I think physicians can learn from that and use it, and hopefully the new generation of docs coming up will be able to use all this technology as kind of, I've embraced it throughout my career. I've seen a lot of developments over the last 30 years I could have never envisioned. And things have been
Yeah,
helpful.
like the microwave wasn't even around when you were a kid.
The microwave wasn't around, right? Yeah.
Me neither. That was the first time you'd bake a potato in the microwave. It didn't take an hour. It took like 6 minutes. It was great. It was great.
We didn't have Zoom, right? So, there's a lot of improvements and benefits. So, I don't, you can't really stop technology. I don't think anybody wants to in the medical field. I think you have to be aware of it, embrace it, utilize it, and learn from it, and help it to ultimately help our patients.
Yes, I agree. And insurance companies are making it a little bit challenging for doctors because they keep limiting the amount of time that you're really able to spend with patients, and the billing things and getting procedures through when things are for the best for the patient. Sometimes it's a little challenging to get over the healthcare hurdles when it comes to that. But I promised that we wouldn't jump into healthcare. We would keep it to 2 topics instead of 3. Because that's a whole nother conversation.
That's the whole. We could go on another hour about that. Yeah. So
this is funny. Most of our conversations have included like a glass of wine in my hand, at least.
I should have said something. I don't know. I'm known for my Fireball whiskey, but I don't have one right now.
That's true. We'll do that next podcast after dark. After dark, not during working hours.
Right. Exactly. Yeah.
But this has been great. So thank you for, doing what you're doing for women and for men. I actually have a friend from college who has breast cancer right now. And I'm sure your procedure is targeted for any tumor of any person that meets those requirements.
Yeah, I think that's a good throw in at the end, is that if you're a male and you're listening to this and listening for your female counterpart, perhaps, or just to hear a nice podcast, don't discount the fact that you could get breast cancer, because I've certainly treated and diagnosed several, many men who've had breast cancer. So if you feel something and it doesn't seem right, there's a lump in your breast, go get it checked out. Don't just let it go, because it could certainly be breast cancer in a male as well. Good point.
Yes, exactly. Okay, I will let you carry on with the rest of your day. Thank you for this education. Really appreciate it.
Well, thanks, Jess, for having me. This is really great. I really enjoyed it, and hopefully your audience enjoys it as well. And if they want to get information, they can Google me, or I guess.
Yes, actually, where can someone reach you? I don't want to inundate you with phone calls if you want them to contact you in a different way. But what's the best way if someone does want more information about this procedure, or just more about you?
Procedure in particular, the ICE3 trial, you can certainly look me up. I'm at Princeton Radiology. I give you my email. It's K Tomkovich, Tomkovich MD at gmail.com. You can email me. I always give out my cell phone number to my patients. I won't give it out here because I don't want to get inundated with cell phone calls. But yeah, you can certainly email me. I'd be happy to discuss individual cases, or educate more people, give more information out. I think that's really great that you're offering this to your audience and to women throughout the country and around the world to get educated. And I think that's really the key in this whole thing is to continue to, the more places that I can talk about this and the more people that we can educate on this topic of breast cancer cryoablation specifically, that's what I'm most passionate about. I think the better. And so, yeah, I'd be happy to speak to anybody about it in the future. And I appreciate your time and having me on to talk about this topic today.
My pleasure. You can get early detection, have breast cancer, go in, get it cryo taken care of, and then go to lunch.
That's the goal.
Advancements in technology. But thank you. Thank you for advancing that technology. All right. I will talk to you soon, Ken. Thank you so much.
My pleasure. It was great being with you. Thank you.
Appreciate it. Bye-bye.